Well, hello everyone, and welcome back. If you have been joining us or going with us to EULAR 2021 Scientific Congress, we are back for debrief number 5, right?
Yes.
Debrief number 5, and we're not done. We still have a few more after this one, but today we have myself, Deb, and Katie. Everyone will say a little hi and a little introduction into the core team going this year from International Foundation Autoimmune Autoinflammatory Arthritis, or ARthritis for short. And also Patrice, one of our volunteers who went with us last year, is continuing with us. And then we're bringing in Leslie, who's going with us for the first time. So you just have a whole bunch of different people and different perspectives here at the table. And what we are essentially doing as an organization whose mission is to help all people have voices, all patients be able to come to the table, not just us all the time. So that's where Leslie, and then we got to give a shout out to Eileen, who couldn't join us for the debrief, but also going with us. And we want to make sure that everyone gets that opportunity to learn and be connected as equals with other stakeholders so that together we can impact education, advocacy, and research. So my name is Tiffany Westridge Robertson. I'm the CEO of the organization. I'm zooming. I'm zooming in from St. Louis, Missouri. Our brains we're getting the fog a little bit. We're all a little flaring.
It's Friday.
Tired. So I am zooming in from St. Louis, Missouri, in the United States, which is where our headquarters is located. And I live with axial spondyloarthritis. I'm going to turn it over to Deb. Hey, Deb.
Hi there. I'm glad to be back. I'm Deb Constein. I am in the Madison, Wisconsin area. I have rheumatoid arthritis, diagnosed around the age of 13, so long journey with that. And just happy to be back. I just love digging my fingers into all this stuff and learning. I'm at this point, and now we're over a week into this, my head is everything is mushing together. So it's good that we talk about this ahead of time before we're taping, because otherwise I think now was that session or the other session?
It is all blending together. But you know what, Deb, I think another reason it all blends together is because, as we'll talk about after everyone does the introduction a little bit more, there are themes that emerge. Yeah. And when themes emerge, you hear similar things over and over, and it's hard to differentiate. So did you say where you're tuning in from?
Madison, Wisconsin. Yes, I did.
Okay. Sorry. I'm a little worried how this one's gonna go. Let's go to Katie. Hey, Katie.
Hi, I'm Katie Simons. I'm from Metro Detroit. I am the Senior Program and Communications Manager at ARthritis. I am both new to EULAR and new to ARthritis. I've been diagnosed with RA or JIA for 19 years, and I'm happy to do another debrief.
Awesome. All right. Hey, Patrice.
Hey. Well, I'm glad everybody's tuning in. Welcome. My name is Patrice Johnson. I live in Northern California. I was diagnosed with rheumatoid arthritis 10 years ago, and I'm happy to be returning to my second virtual EULAR Congress, excuse me.
I know, but I messed that up as well. Awesome. And last but certainly not least, hey, Leslie.
Hey everyone, I'm Leslie Matt-Welsbacher. I'm also in the Metro Detroit area, and I was diagnosed with lupus and rheumatoid arthritis in 2008 at the age of 22.
Wonderful. And tell them about your blog as well.
I blog about living with chronic illness at Getting Closer to Myself. So that's gettingclosertomyself.blogspot.com.
Awesome. We started having her do that in the beginning because we might forget at the end. So that's just what happens. Okay, so what is the topic today? Well, one of the things that we really enjoy about the EULAR Congress, and EULAR in particular, is that they have 3 pillars. If you've gone to our debriefs, you've heard this, so we won't go into it and in so much depth today, but essentially there's the healthcare professional, there's the researcher, and then there's actually a patient pillar. So there's a lot of material that's geared towards patients, but Europe and Canada were the original, in rheumatology anyway, the original continent, country, depending on where you are there, who started inviting patients to the table as equals in research. And that's the key word here, is equals. And that started in the late 1990s. So the United States, we're a little behind. We started a lot later. Mainly, it came to be with PCORI, mostly around 2010, 2011, when it really kind of stepped up. There were little things splattered before, but for the most part, so you know, they're ahead of the game here. And Maarten DeWitt, shout out, who has become a dear friend of mine and Deb's as well, and a colleague of ours on some projects that we're working on together. He did a lot of the presentation in here, and I wanted to point his name out in particular because I'm going to say Patient Research Partner, or PRP. That was a term that Maarten was the lead author on and helped EULAR develop back in, I think it was published in 2010, but it originated in an OMERACT, which is Outcome Measures in Rheumatology, an OMERACT meeting in 2002, when patients were invited for the very first time to sit alongside the researchers, and Maarten was one of those original patient research partners, or PRPs. And then it was so successful, EULAR came to him and said, can you help us define this? And so that has become the staple of collaboration. And essentially what it means is that the patient sits as an equal partner with the research team from the beginning to the end. So it is not an advisor position. It is literally part of the research team. And you'll hear us talk a little bit about OMERACT later, because I've been a patient research partner for OMERACT since 2016, 17. And then I brought Deb on for a project in 2019. I think.
Yeah.
And so we're definitely involved. And we also, if you, after we talk about it, and if you out there are a person living with these diseases and you want to get more involved in OMERACT, let us know, because we can help with that. So that's what a patient research partner is. And then also what we're going to talk about mostly today is a session that was called Improving Collaborative Research and Patient Participation in Health Decision Making. So essentially a whole session just about us and how our voices matter when we're talking about health decisions. And so it is about research, but they also talked and compared it to clinical, in the clinical setting. So two things. First of all, when you think about a clinical setting and going into the doctor, if you are speaking and you are talking and you are communicating and they are asking you questions, they're essentially interviewing you or having open dialogue back and forth, and they're taking your opinions and putting them towards your treatment plan, that is shared decision making, and that's utilizing your voice in your own participation in health outcomes in a doctor setting. We've actually, as an organization, taken that one step further in a series called Rheumy Rounds, which is an extension of our talk show, where we sit with rheumatologists as equals and have these conversations outside of the office setting. So that is one way, but they didn't focus too much on that this time. And they did also clarify that when you're a patient research partner or you're doing this research, it is very different than if you're thinking about, again, this advisor role or being like a subject in research or being part of a clinical trial as, you know, a participant. You are literally on the research team. So we just need to make that very clear, because there's a lot of different ways you can be involved in research, but that is a very specific role, very, very specific to being on the research team. I am going to first, I would still want to mention something about what Maarten said, but I want to just kind of open the floor, because I've been talking now for 5 minutes straight, and just ask everybody some of your general overall thoughts about the session and, you know, the idea of a patient research partner. If anyone has anything.
Well, I guess, as you mentioned, you know, America is a bit kind of behind the times. So I'm glad that the conversation is happening to begin with. I'm glad that there's more and more being developed, more resources, tools, training, education. I'm glad that it's progressing and being more inclusive and involved.
Me too.
And I'm bummed that my audio is working again. So sorry about that.
Oh, okay. No problem. Let me also ask too, in addition to that, we could still answer that same question, but maybe just your general thoughts about research partnership, or is that a new term to you? I mean, how familiar, like Patrice, Leslie, how familiar were you with that whole idea of that specific type of patient engagement, which is a little different than being on an advisory panel or being, something like that. I'm just curious of your thoughts.
Yeah, I had never heard the term until I became a volunteer with AI arthritis. I didn't even think that anybody was interested in my opinion, my experiences, my journey with my disease. I just didn't think anybody could care less about me. But then when I joined AI arthritis, it opened up a whole new world. And Tiffany and Deb, who are at the helm, and now Katie, have been guiding me along that for the last year and a half. So it opened a whole new world for me, and I'm glad to be along for it.
Oh, well, thanks, Patrice.
That is like crazy to hear, because again, I know that you're widely involved with lots of other things, and you do volunteer that to actually feel that importance. I mean, I love that that's tied to AI arthritis, and just kind of blows me away a bit. But I'm just glad that
I'm glad too. Love you.
Yeah.
Okay. So we gotta get off the love train. So now we're gonna, not that we don't love you, Leslie, I'm just saying that we're gonna go move forward here. So Leslie, as somebody who has been that patient at the table as well, you've done a lot of different type of patient voice work, and I'm curious your thoughts about patient research partner and being that equal on a team, or have you ever done that? I don't even know.
So that term was totally new to me. And I feel like everything that I've done has been much more like a one-off type of thing. And maybe it happens once a year with the same pharma company or the same organization, but nothing that seems to have the kind of longevity that Maarten and some of the other presenters were referring to.
Yeah, that's a really great point too, because and we actually mentioned this debrief was probably gonna be a little bit different than some of the others if you've attended, because we were really focusing on session to session to session. All of this blended together. So we have an outline in front of us, but this is jumping. It just is. And so that's a really interesting point. So one of the things we mentioned before, OMERACT, and Maarten is one of the lead patients that have been involved with that for a very long time. And I have met several other PRPs through OMERACT around the world, because it's an international, and there is a longevity to it, because the projects that you're brought onto, the working groups, this is not like a 1 hour kind of thing. You're invested for years. So it's all year long, and you work for 3 to 4 years just to get to a point where the work that you've done is presented to the rest of the OMERACT group for voting to make sure that you're on the right track. Then it comes back and you're still working in meetings, and and the first meeting I ever went to, actually, I was used to being the advisory voice, right? I think that's what most of us are used to. And they literally just put me on the spot and said, well, you're the patient. What do you got to say? And it threw me completely for a loop. All the eyes were on me, and I went, and that's when I realized, oh, that's what they mean by equal. Like, I'm supposed to be sitting here, not as an advisor, but I'm in this conversation. It was a real eye opener. And I think when you have that type of interaction, there is, they use the term like a relational empowerment. It does make you're invested, and so there is quite a difference. And I think during this debrief, for people out there who are living with our diseases who want to get more involved, there are many ways that you can get involved. But I think to start understanding there's many different ways. So whether it's an advisory position where you're brought in for a couple hours and then, you know, you're done. That is what, when Leslie said, is often with pharmaceutical companies. And what Maarten particularly mentioned in here, when they talk about that PRP has fundamentally started and grown, there's still some barriers, there's still some things to overcome. And one of the things he mentioned was it is not ingrained in pharmaceutical. And what he meant by that was that, and we've kind of experienced it a little bit in EULAR, we couldn't go to the satellite symposiums because those are led by industry or pharmaceutical companies and we are patients. So there is a regulatory barrier where a patient can't just sit fully next to a pharmaceutical company and a researcher without some kind of barrier of an advisory level. So, so there's still a lot to learn, and we're more than happy if you have questions out there and you want to learn a little bit more about how this all works. We definitely are here, and should mention, I'll say it at the end too, launched our AI Arthritis Voices program, which is an umbrella program where you sign up if you're a patient or any other stakeholder, doctor, nurse, government person, anybody who needs to be at the table, sign up for free. And then we will start to let you know of any opportunities for ways to have a voice. And then they could be on our podcast show or talk show. It can be webinars, it can be surveys, it can be advisory panels, you name it. And then if you want to be part of one of our projects, you go into this online community where we've got 2,500 rotating seats where you literally can be matched with researchers, doctors, nurses, just other patients. They're all different spaces or rooms that you can have a voice. So that has launched. Yes. And
That's been a long time coming.
Woo! So several people on this call have been working on that side by side with me for about 1.5 years. So we are very excited about that. But it will be quite exciting.
One thing that I'm actually thinking about is going back to our action council, you know, how in depth of a conversation and multiple conversations about that acronym, the PRP, and how it's, you know, again, people that actually are on the action council are from all over the country, or not even country, world, and the best of the best, and everybody has different terminology too. I just remember that.
Oh, that's a really good point. Wait,
yeah,
that's not even in our notes. So
I know, sorry, again, my head just moving.
That's okay. So first of all, let me explain what the Action Council is. So this was actually, we were very excited. It was brought up in Maarten's presentation when he was talking about some of the top 3 most important things to know when you're learning about patient collaboration and research, and the Action Council was on those top 3. That is a group of stakeholders led by patients, myself, Maarten, and then Cheryl Cohen, who has rheumatoid arthritis, and she is the president of Arthritis Consumer Experts Joint Health / in Canada. And she was one of the original, if not the original, patient research partner in Canada. And then I already told you the history of Maarten. So how I ended up partnering with those two, I just feel lucky. I don't know how I got to be the third pillar in that team, but hey, that's good. And so essentially we put together a group of about 20 or so people. 70% are the patients who have been at the table for all of these years, have been somehow part of a pivotal project or are working in conjunction with a group that is known for patient research collaboration in rheumatology. And we have spent the last couple of years working on the very first deliverable called the Pathway, which tracks patient engagement in the rheumatology research community back from the early 90s all the way to today. It's a living tool. And the goal is for people who are developing research projects to learn from the people who have been at the table, to cite the work that's been done, to build on past successes so we do not duplicate efforts. And part of what Deb was saying is, as we were collecting this, we realized there's a lot of terms out there. So patient research partner to, we say research advocacy when we're talking about research that influences public policy, for example. There is a whole list, and we call them the concepts of patient involvement, or COPI for short. And what we learned was we need to track those, because internationally, if you call something that means the same as PRP something different,
Yeah,
and
the
that gets
acronym. Yeah.
published,
Mhm.
then as other researchers are looking for collaboration, they're not going to find all of the data because it's going to be listed under something else. So we're tracking that too, so that people developing projects can say, oh, well, I thought, PPI or just throw an acronym out
Yeah.
meant this, and it actually in a different country or to a different group means that. And then what'll happen is, knowing that when there's research pulled up, we can measure the impact of our voices longitudinally instead of just piecemeal here, here, and here. So it's a really innovative project. We're very, very proud of it. It houses, we are the organization that is the lead. And so it is housed and funded through our organization. And I'm going to do a shout out to Bristol Myers Squibb, BMS, because they have been our biggest supporter. They have not backed off with helping us. If it wasn't for them, it wouldn't exist.
They would. I mean, they were the first ones to actually believe in us.
They have been the only ones to continue the funding.
Yes.
So if it wasn't for them, got to give them a shout out. But thanks for bringing that up. So we'll definitely give you more information. That tool is launching end of June. So I'm going to turn it over now to Ms. Leslie, because you had some really interesting insights from attending this. So I'm going to let you lead from here.
Thank you. So one of the things that I found really interesting was that the concept about payment came up several times. One of the presenters mentioned during the Q&A that he has to take time off from his regular job and does work for the various projects and organizations he works with when he has vacation from work. And it just resonated with me because for me, I've been chronically ill for 13 years. I somehow magically got involved very quickly from blogging and attending conferences and advisory boards and all of that. And it's a constant struggle, especially I have a full-time job that I don't necessarily love. I do it because it pays the bills. And there's just a constant tension of wanting to do the things that you love that don't necessarily come with payment, especially when you're dealing with companies, especially companies where they can afford to pay you and compensate you for your time. And so it's just, for me, that's been really a philosophical challenge. I mean, it's a challenge that really gets me really at my core. So to hear somebody else talk about that and express that, and I think he also mentioned something about that he gets paid for his travel and not actually for the work. And I know that some of that is regulatory, but I know, at a lot of advisory boards, especially with pharma, it's like, well, you're the patient, you're the expert. We want to hear what you have to say, but we want to hear what you have to say for, 3 hours once a year. And it's like, no, hire us. Like, if we're so important to you, if we're so valuable, then, give us a seat at the table, make us equal partners more than just once a year for 3 hours at a time. So I just, it was nice to hear that, because that's not something that you normally hear at conferences and hear expressed by other patients in that kind of venue. So I just really appreciated that. And I don't know, if other people struggle with that, but I know for me, it's just, it's a big issue for me, and I always joke that I never do anything for the money. It's not about the money, but at some level, it kind of is about the money. I mean,
yeah. I'm gonna let everyone else comment on this. I just want to throw out really fast. If you ever are asked by pharma to do anything, do not accept it if you're not paid, first of all. Do not. I mean, there is no excuse for that. We nonprofit organizations, things, there's that's a little bit different, but there is no reason to any person out there living with heart diseases, if a pharmaceutical company, a for-profit company contacts you and wants to interview you, you absolutely should be compensated for that. So and we can go into more about how what we're talking about with patient research partners. I can explain that more in a minute, but I want everyone else to weigh in on their thoughts and, you know, when they were listening to all of that.
Well,
Leslie, you mentioned,
go ahead.
You should go first.
Oh,
No,
okay.
you first.
Thank you. I started attending conferences about 4 or 5 years ago. I have been to many of them where I paid out of pocket. I live on the West Coast, and most of them have been on the East Coast, so my airfare is always double. And they're always, yes, and they're always at these expensive hotels because they have the conference rooms there. So I have spent, one of them, I spent well over $2,000 attending the conference. Mm-hmm. And it's not, you know, I don't go home and say, darn, you know, somebody should have paid my way. It is more of a passion and an enrichment for me. But on the other hand, it can get expensive if you go to conferences more than once or twice a year.
Patrice, I know exactly what you're talking about. And there are many patients that aren't able to go to these conferences because of the barrier and having to pay their own way. And that they're on, oh my goodness, I total fog right now, but they're on disability. And yes, you know, you're paying for your life through disability payments because they can't work, because they're disabled because of their disease, and there's no way they can afford to go to these. And that breaks my heart.
Which is exactly why we're doing Go With Us to conferences, by the way.
Yes.
I mean, that's one of the reasons, it's one of the bullet points, and we're developing, it's a pilot program. But as we move forward into 2022, the goal is, especially those who cannot travel, that they still get some kind of conference experience. So that was a good point. Katie, you were going to say something too.
Being a patient is expensive. You need all the, you know, you have good health insurance and pay for the drugs and take the time off to go to doctor's offices or get infusions or anything, or buy mobility aids, or I had to buy a car a couple years ago, and people was like, oh, it's so nice, it's like, you know, nice fancy cars. Like, I'm kind of forced into a nice car because I need the accessibility, I need everything to be automatic, so I don't really have a choice. But you know, I'm kind of stuck spending more money to deal with all the other little things that come with being a patient. And then I was also going to mention, Leslie kind of touched on this a little bit, the issue of time. Our time is really valuable, especially as people with chronic diseases. We don't get that much luxury time. So when you want us to spend that precious time that we do have, you know, it's more valuable.
Good, that's a really good point. So I'm going to circle back to talking specifically about patient research partner, because what I think those who do participate in our mission, as I mentioned, I mean, our whole mission is to help others have a voice as equals with everyone else. So we're doing everything we can in our programs to make that happen. In saying that, of course, we're a nonprofit. We cannot possibly pay everybody to come to the table. I mean, otherwise we'd have to be a for-profit company, right? Because then what's the point of being a nonprofit? And that's our whole mission. So we have actually found a little bit of challenge recently over the last couple of years because of the payments of different types of patient voice in research, which could be advisory panels, things of that nature, that where pharmaceutical or for-profit companies are paying for, or a nonprofit is facilitating, but they have a grant. It's a fund from usually a pharmaceutical company. So, you know, it's not from donations, it's from a grant. There's an actual project behind the scenes that's happening. So that's one way. But the thing about the patient research partner, as I mentioned, this started not in the United States. It started in Europe and in Canada, and the whole groundwork, the idea was bringing the patients on these research teams. But I need to preface, the researchers, the doctors aren't paid either. So it's not that the patients are the only ones not being paid and giving all this time. Nobody's paid. So you're all doing this volunteer for the greater good of the community. I can tell you, when I went to EULAR in person, I was very grateful, because even though there's a group of patients that can be patient research partners on the team, only 20 are brought to the actual meeting that happens every 2
So
years.
you're talking about OMERAC, not EULAR.
Yes, OMERAC. Did I say EULAR?
You said EULAR. So
I'm sorry, I meant
yeah.
OMERAC.
So I wanted, yeah.
Thanks,
Yeah.
Deb. So
Yeah.
when I went to OMERAC, I was as a patient research partner in 2018 to Australia. I've never worked so hard in my life. I've never seen anything like it. I remember showing Deb my schedule, 8 o'clock in the morning till 10 o'clock at night, and
Working lunches.
and even
working
during
dinners.
even during lunch, it is a working lunch. You're one or two of your working groups, and then the meetings go. You break for dinner. That's the one time where there is a real break at dinner, and then you go from 8 to 10 to another meeting, and then it's like, oh my gosh, go to bed, wake up in the morning. And at some point in those 4 days, you get a 3-hour window break. Now, in saying that, they accommodate for patients. So, but like, if you have to go sit down somewhere, whatever, but you are expected to be there. They're flare or not, you're there. I mean, that's part of the reason why they only bring 20. You have to make sure that the people that you're bringing are gonna fight through it. It was the most rewarding thing maybe that I've ever done. And I think that Maarten talks a little bit about that when they're talking about that relational empowerment. I didn't get paid a dime. They paid my way to get there. They paid for my hotel, and the food is off the chain because remember, doctors, researchers, well-renowned people from around the world are donating their time, and they're always in these kind of exotic locations too, because you got to give somebody a reason to want to be there and take a week off work, right? And so there is some incentive in that way. But I think they tell you when you go, you can't really explain what it's like until you experience it. And that's the only way I can explain it. But when you get through, they basically tell you you're in this club that is part of you forever. And it is. It's like you graduate into this exclusive group of people that you have this connection with, like an unwritten connection. I can't explain it. It's just so rewarding, and I would do it over and over and over again. And yeah, I almost got a little teary-eyed there. And so I would just do it. I'm so thankful for the opportunity. But it is very different than sitting on an advisory panel. Or something where absolutely I would expect to be paid. But Leslie, I wrote down something that I thought was a really interesting point you said about that advisory panel that I'm going to take to heart and try to incorporate in our Voices program. And when we talk to pharma, is you said, I want to be there more than 3 hours a year. That's a really good point. You know, one of the missing things in research that is known is that the follow-up is missing.
Mm-hmm.
Because what'll happen is they'll collect your information, they bring it back to whomever, and then inevitably those people are going to look and say, well, I wonder what they meant by this, or I wonder what they meant by that. I wish they could expand. And I think that's the way, even though they were talking about patient research partners aren't so much in pharma, and this is as you can maybe hear from what I'm saying with Omer, you're literally in the trenches working side by side with these people. Even though pharma is there, by the way, pharma is at OMERACT. There are pharma representatives there. In saying that, I think that they should really consider when they're making these advisory groups that they are a year contract. or something like that, so that they can go back and ask you to expand. And you might think something after the fact too. And obviously look at what we generate when we have conversations. So I'm going to definitely bring that up. That's a great conversation. Is there anything else, as we're talking, anyone wants to bring up? We're talking, about patient research partner or collaboration or anything that was seen in the discussion points.
One thing that I remember specifically is, when I have been asked by pharma to give my opinions, it's like an hour, 2-hour video call and a Zoom call or whatever. Usually you have to actually jump through hoops to find out what the outcomes are.
Oh, yeah.
They don't report back about what has been learned overall from all their conversations and stuff. And there's nothing more frustrating, in my opinion, being one of the people that are sharing their experiences and knowledge and things like that. That drives me nuts. Anybody else?
Yeah, definitely. Yeah. I remember I had this one experience where we were asked to review marketing materials and everybody at the table hated them. I think there were 9 of us and we were like, these are terrible, get rid of them. And they were like, oh, well, they were all published last week. And we're like, then why are we here? What are
Oh my goodness.
So I totally, there's no follow-up, but sometimes it does feel like you're just a box to tick. Like we have to show it to patients before it's, put out in rheumatologist's office. But it's not like the intent behind it isn't there. It's just like, oh, we talk to patients, cool, bye.
Yeah,
there's a term for that, Leslie. There's a term for that, and it's called tokenism.
Yeah.
And that is something, and that comes up, that's actually when a patient research partner, when regardless if it's OMERACT, GRAPPA, which is, I'm going to mess up, I don't have it in front of me, is the group for psoriasis and psoriatic arthritis. They're kind of the governing international group for that, and they use patient research partners. So it's not just, we were saying OMERACT, but it's not just OMERACT. EULAR itself, all of their programs utilize patient research partners. So it is an adopted practice that just happened to originate from an OMERACT meeting. And saying that, oh, I lost my train of thought. I just looked over and I saw something, and it made me go off the darn brain fog.
I know.
I lost my train of thought. It'll come to me as soon as okay, can't remember. Move on. Totally lost it. All right. Can't remember what I was gonna say. Yeah. Okay, so do we want to continue talking about this since I can't remember what I was gonna say, or do we want to move on to Rheumamap, or where do we want to go from here in our debrief?
Rheumamap sounds good.
Okay, let's do Rheumamap. And then if I remember what the heck I was going to say, but I don't know, I think it's really gone. I don't remember.
Sometimes you can actually, it's like just right
It's
there.
not
And
even,
come
it's
back.
not,
Yeah.
it's not
And
even
you
right
come-
there.
And when it's just like, that'll come to me in the middle of the night some night.
Oh, I'll rewatch this and then I'll go, oh, so
Yeah.
I can't remember what triggered me to say all of that.
Speaking of that, Deb, you asked a question on the last debrief about methotrexate. We're talking about a survey, and you asked if juvenile idiopathic arthritis patients and the methotrexate they were using, if it was liquid or pill form,
Right.
and anticlimactic, but they didn't specify. So, but question answered.
Yes. She did look it up and she sent it on to me. And she actually sent the whole BMJ article to me. And I was like, it was like a funky question, but it just stuck out to me at that moment. So I thought I'd bring it up.
Okay, well, we're going to go to Rheumamap. And what Rheumamap was, and it was still in the same session, one of the things that I noted immediately is it was presented by the president of EULAR. And the first thing that he said is it was uniting all different stakeholders together. And he said, and the most important stakeholder, the patient. And just the fact that the president of EULAR, that's how he introduced this tool. And essentially it's a document that will identify the unmet needs. That they're tracking research, they're tracking what's been done, and then so they can look at it and say, what are we missing? So they have it looks like a couple dozen different diseases to start with, and the purpose is to look at these, see what the main challenges still are existing in research, and then sort of connect the dots to say, ooh, this is where we're missing. We need to go research this. And when I say this every time we go to EULAR, I feel like we are so European as an organization, because every time I'm like, that's what we do. We connect the dots, we find the missing gap. So the synergy is so strong. But that's just something we wanted to mention, because that is a tool, and much like the pathway tool that we talked about earlier with the Action Council, it is a form of tracking there's a reason for tracking. So it's really cool to see two different tools in rheumatology emerge that is going to be tracking history in some way, shape, or form, so that we can evolve and move forward and address issues that are most important to our community. I wanted to just make one point. It wasn't clear. I don't think, maybe I'm wrong, so let me know if you disagree or what have you, but they talked about that this tool in Europe will also have a societal influence in public policy. So I'm going to ask, did anyone does anyone know kind of along the lines of how they're going to do that, or how they're going to utilize that?
No.
Okay, so the only reason I was able to read between the lines here is, thankfully, in 2018, our organization, and shout out CreakyJoints, were the only two organizations that were non-European based that were invited to attend EULAR Paris meeting. And that is the group, the pillar under EULAR where the patient organizations live. And so, because we're international in scope and we've worked with EULAR in several capacities, we were fortunate enough to go. And it was a meeting in Brussels, Belgium, and we got to go to Parliament. So it's basically like going to Washington, D.C. in the United States, so that we went to Parliament. And it was one of the most amazing experiences I probably have ever had. I learned so much about how policy works in Europe. And when I was there, I did not know how rheumatic diseases in the workforce, they talk about it a lot, and you might have seen it a lot in the different sessions. It is ingrained into their public policy. There is a societal law in their governance of Europe where employers must consider the limitations of people with rheumatic diseases. It's not like an optional. It is part of, and the idea is that if these people who have young onset, who have many challenges, brain fog, fatigue, all of these things that come along with our diseases, if they do not have the accommodations, they cannot be fully functional. So this is all ingrained into their policy, which I find fantastic.
Agreed.
And it's not at all here. And so, I mean, it is to the extent of you have legal rights to ask for accommodations, but it's not a governing law that's just ingrained into the structure of this country, where employers essentially need to understand the limitations and know that there's brain fog and fatigue and all this. So when they talked about that tool, they mentioned specifically, quoting, there's a reason, because there's 60% of absences that the patients who have these diseases, you have to call out of work. And for those reasons, they need to make sure that this tool and showing the unmet need is going to help them influence public policy and keep the patients in the workforce longer, because in turn, then they feel like they can give back to society and they don't have to go on disability. So
there's many people here in the United States that feel, again, that they want to feel valued and, you know, for their time. And if they are on disability, they can't. So agreed, that would be, that would be amazing.
Yeah, he also had mentioned, it was another session I watched about over in Europe, you know, from time to time, people that are living with these diseases need to take time off to take care of themselves. And let's say they're gone for weeks at a time. They also have a program of re-entering people into the workforce and staying in the workforce.
Absolutely. Yeah, it's something that I was very impressed about when I went, and I really, really would love to see that translate somehow more into other locations. But so that I think that's a great asset to that tool as well. And then last but not least, I'm not going to do a full review. We've talked a lot about it already. As we knew we would, blending. There was another session that was called Expected Outcomes of Multidisciplinary Interventions. And essentially, there's a couple themes that have come out that we just keep seeing. And one of them is this idea of multidisciplinary intervention. And the more we've gone to EULAR, the more I'm starting to see, we just kind of said, oh, I'm recognizing this. Now it's becoming, to me at least, a lot more clear that as the inflammation of the umbrella, which is theme one, the inflammation is driving everything. And if it's not caught early enough, the inflammation can get out of control and cause comorbidities. So that's theme number 2. And with the comorbidities, then we have to think about other treatments, and other treatments like blood pressure or, you know, heart disease, or things that some could be caused by our diseases, some are just living on their own. But when we think about that, we have to start thinking about multidisciplinary care. So now I'm seeing the road. I get it now, because before it was just theme. Now I can connect the dots and see how how it's all connecting in there. And this session talked about multidisciplinary interventions and the need for this kind of full body treatment, which we've talked about. I think everyone here agrees. We've talked about diet, we've talked about exercise. We all know that we're individual, not one size fits all. But essentially, again, our dear friend Maarten, who was one of the featured speakers in there, he's kind of a big deal at EULAR. You're gonna hate me for saying that. He's like, no, I'm not. But he is. And so he was in this one again, and he talked about OMERACT as far as creating domains. So all I'm going to say about it is we talked a lot about what a patient research partner is, but again, it doesn't matter. Maybe this is where I was going before. It doesn't matter if it's GRAPPA or if it's OMERACT or if it's EULAR. There is a very specific way that you want the patient voice to be incorporated. It's very, there's a process. And because when you're talking to researchers, or you want to make sure that there's a process there so that they can measure it, and that's obviously very important to people. Oh, my cat's, oh, you can't see it. Like, my cat's right here, but you can't see because I have a little screen on. So they talked about maybe being able to use the OMERACT process as that measuring tool, or as that format to integrate when we're thinking about interdisciplinary care. So all we need to really say for this is they gave a whole presentation on, but if you think of an onion, so they call it the OMERACT onion, and there's layers of the onion. So if you're a person living with the diseases, like we'll just do a little game right here. Wasn't planning on this, but so think about your disease. Everybody here, you know, like if it's rheumatoid arthritis or lupus or etc. What is the number one symptom? Just shout it out for you.
Pain.
Pain.
Fatigue.
Yeah, pain, fatigue.
Pain, fatigue, and we could say brain fog, and we could, you know, there's all of these different things, right, that come along with it. And so essentially what happens is they need to, OMERIC is mainly clinical trials. So what ends up, I think he's going to break through the barrier. Yep, there he goes. So what happens is they are trying to find different domains of what is important to study and research and in clinical trials, and they need the patient input. So what happens is you put the most important things to study on the inside of the onion, and then it goes to the out. So maybe pain and fatigue are in that inside of the onion, and then maybe brain fog is on the next, or it's on a tertiary level. So that's how it works, and it's the easiest way to explain it. And then all of the different stakeholders have to agree, and it goes through years of process. Well, they were saying, well, maybe that's kind of the same thing that we should do when we're talking about multidisciplinary care, is what's the most important thing? You know, is it your rheumatologist? You know, what is in that middle circle, or the middle of the onion? And then thinking of it as domains, and to bring some organization to it. You know, so that's really where they were going with it. And I thought, that's it. I never really thought about that and adapting it the other way. So that's the main takeaway, because we kind of talked about everything else here. But anything else that we missed? Any major points that we missed? No? Well, Patrice had a fantastic idea about how to close this out. So we've talked about the difference of having pay versus not having pay, and that there are these different roles, there are these different types of collaboration and research that maybe, especially in the United States, aren't necessarily as well known. I think we as patient advocates know the advisory part a little bit more, and while people in other areas know that research partner level a little bit more, not so much the pharma. So that's where there's kind of a disconnect in an international scope of patient collaboration, and where our organization is struggling a little bit when we're trying to invite patients to the table, somewhat pay, some, well, we hardly ever, anybody outside of the United States, I don't think has ever asked for it. And so it's a little different. But in saying that, since there are different ways, and volunteering is one of them, volunteering at organizations or doing experiences where we're paying for people to be able to go to conferences, Patrice thought, why don't we give our opinion on what we think about this? And I said, I think that's fantastic. So Patrice, why don't you lead off?
Oh, I knew it. I was trying to think what I was going to say while you were talking, so I didn't sound like I was just off the cuff. So being involved with AI arthritis, and I also volunteer for a couple other organizations, being either a volunteer, an advocate, a patient research partner, it is so important to me, because when I was first diagnosed, I probably spent the first 6 years, I took my medication and just went on about my daily life. I didn't know anything about volunteering. I didn't know anything about these organizations. So not only for the information and the research and the tips and tricks of living with our diseases, but it has just enriched my life. Sorry.
Oh,
so much.
Yeah.
It's,
right around your face.
Yeah.
I just feel like I've been given not a second chance, but maybe a destiny and a purpose of what I do. Sorry.
Awesome. No, that's fantastic. That's thank you for that. I appreciate it. Who else wants to throw their
and you don't have to cry.
Well, I will. My position's a little different. Again, I, graduated college with a double major, dietetics and biology, and became medically retired from those positions. And, it's just my way. And I am blessed to have a husband that's able to, that I don't have to work a full-time job. He allows me, doesn't allow me, but you know what I mean.
You got it.
Yeah. He, again, is super supportive of all of my volunteer work. And you know, he also knows that there's several things I do that frustrate the dickens out of me. And as far as volunteer work goes, but then, you know, with AI arthritis, it is like super impactful, and I feel like I'm making a difference. So that again is a way for me still using my brain and, you know, giving back to others and helping as far as all of that goes.
That's
So
awesome. Great, thanks. Anyone else?
I know from the nonprofit perspective, like we get nowhere without volunteers. Volunteers mean everything to us as far as just this, you know, the time, the input, the expertise that you know, it's not just donating one thing. It's so much more that you are willing to give to us. So
And I have to
it's
say,
very
too,
impactful and
seeing the
meaningful.
end result, which is something I kind of mentioned with the OMERACT experience. I know, you know, Deb and Patrice, you all have been with this AI Arthritis Voices program, building it for a year and a half, and it's finally here. And I mean, just seeing something, the end result, I think it speaks volumes too.
yeah,
You know,
seeing visions, because I remember being on a conference with you and you had your brain sitting on like 5 pieces of paper as we were sitting outdoors, and you were explaining the concept. So even seeing it from the visionary
yeah.
through.
That was funny. We were actually in Amsterdam, and I had about 12 pieces of paper laying all over the floor, and I was trying to simulate a website and how everything would. And she's like, okay,
Yeah.
okay. Leslie, did you want to add anything?
Yeah, I mean, first of all, I just want to say that I'm so grateful that AI arthritis gave me the experience to attend EULAR, and I'm grateful for all of the opportunities I get. I hope it didn't come across as I don't take anything for
Oh
granted.
no, you spoke well. You didn't. Yeah, you did not. You did well.
But I mean, I agree with Tiffany. I hope that we can kind of move that European model more to the US. And I know I'll keep advocating and keep saying, why don't you just hire me? But self-promotion is hard. Even just plugging my blog at the beginning, that's hard for me. So but I think it's great through this experience to have been able to see that we don't necessarily have to reinvent the wheel, that these things kind of do exist in situations in other places. So I'm definitely happy to see that, and I hope that we can push it forward.
That's awesome. And I think that is just a really good takeaway of this particular debrief. That was really all about us, all about the patient voice, and opening eyes to the many different types of collaboration, and many that have been in existence for decades, that are about rolling up sleeves, and the reward is seeing the end product and knowing, wow, I was part of that. And I think that's what our organization has always been about, is in being heard and making your voice as a contributor to the end result. So, you know I do this for a living, as well, but I do still volunteer. So like all the work I do at OMERACT, I mean, this week alone, I'm on the adult onset Still's disease working group that just started for OMERACT. So I had that meeting on Wednesday, followed by a 3-hour meeting for the American College of Rheumatology, sitting on a working group to help create e-health guidelines for fellows and rheumatology students, and then to adopt. And there's no pay involved in that either. So I do still volunteer, and that was 4 hours of my day on Wednesday. And of course it takes time in between. So because I see the value, and I want to be part of that and use my knowledge for that as well. So that's it. That's all I got. And this was a real special one today. So I appreciate all of you being here. And we still have a few more things left to debrief. I know we still have the communication with rheumatologists, a little bit of COVID, And I don't remember what else. But I know
It's on some documents, yeah.
we have a few, we have a couple, at least two, but probably two. And then I'm going to do mine on spondyloarthritis, but we are definitely coming close to an end of wrapping up EULAR 2021. If you want to learn more, we still have all of the other debriefs on the YouTube channel as well. And if you go to aiarthritis.org/EULAR, and depending on when you're watching this, there'll be a /conferences, I believe, and then it'll default to the same page. You can learn more about joining us because we'll be doing this again when we go to ACR. So that's it. That's a wrap. Thank you all for being part of it today. And we are tuning out from EULAR 2021.
Au revoir.